Hello and welcome everybody to the SFE and YDEF Taster Day, which is titled the National Endocrinology and Diabetes Taster Sessions. Today we're looking at why diabetes, looking at career insights and top tips. It is fantastic to see so many of you joining us today, and we hope the session is really useful. We have three incredible speakers, and we will ask each of those speakers to talk about a diverse area of the specialty and what life is like as a trainee or as a consultant, as a practitioner in the specialty. At the end, we will then have a series of questions. So we won't ask each speaker questions individually. We'll do a panel Q&A at the end. To facilitate that, as we go through the presentations, please pop any questions you've got in the chat so that we can record them and ask them to our panel at the end. So just to note that the session is recorded and will be available to review afterwards as well. But without any further ado, we'll move on to our first speaker. Our first speaker is Kerry. Kerry first became a registrar in diabetes and endocrinology in 2007. She's completed research in severe insulin resistance with the University of Cambridge. After the birth of her first child in 2011, she became a senior clinical fellow in diabetes and endocrinology, again at Adam Brooks, and she released her national training number. She left medicine completely in 2014 before returning to medicine when the pandemic hit to help out. And she's now been recently reappointed as a registrar to complete her training. Excitingly, and I had a look at this as an amazing award, she was actually named a winner of the 2022 Time-Wise Power List, celebrating inspirational part-timers in senior roles. So I hope she'll provide us with some inspiration about the specialty now. Thank you.
Good evening. Thank you for that introduction. So, as Tim said, my name's Kerry Thackeray, and I have just recently started again as a registrar in diabetes and endocrinology. And I think most of us, when we think about starting our careers, we assume that everything's going to go in a fairly well-trodden path. We're going to be, as you are now, we do foundation years, then we do our core medical training, then registrars, then pop out as consultant. But for me, and I think probably for most of us really, it's more a bit of a meander. Tim's already said a bit about what I was doing, so let me catch you up on what my career journey's been. I graduated in 2003 from the University of Aberdeen and probably didn't graduate with any great interest in diabetes and endocrinology. But then I'm of an age where you did 6 months medicine, 6 months surgery, and then some medical SHO jobs, and met some consultants who really encouraged me, thought I might be interested, took me to clinic. I passed my MRCP in 2006, and then made the big journey across the border as a registrar in the east of England in 2007, working in Ipswich, Adam Brooks, and Southend. During this, I took another one of these little detours and did research into the genetics of obesity and severe insulin resistance at Cambridge University, achieving an MPhil, because during this time, I was also working on another project, which was these two. And that made me sort of evaluate what I wanted out of things. So I relinquished my training number and became a senior clinical fellow doing just diabetes and endocrine clinics in Hinchinbrook Hospital in Huntingdon, and then Adam Brooks Hospital. Then I'd continued my project, and this is what the family looks like now. So in 2014, I decided to give up medicine entirely. And for those of you not familiar with Mumsnet, became a stay-at-home mum for 7 years. I gave up medicine entirely. I didn't do any paid employment and spent my time bringing up this lot. But then you may have heard of a wee pandemic that happened in 2020. The GMC wrote to us all who had given up our license to practice and said, can you come back to work, please? And I did. So I returned during the second wave, feeling pretty nervous about the huge gap that I'd had. I'd always hoped there'd be a way back to medicine, but I hadn't quite worked out how. Initially, I was sent to work on a geriatrics ward before I was repatriated to diabetes and endocrinology. had a wee trip through critical care, which I think we all did, and was really reminded of just how much I love medicine, how much I love diabetes and endocrinology. And thanks to some really supportive former and current bosses and my training program director in the East of England, applied again for registrar training through the alternative certificate. And that's a way perhaps more relevant to international medical graduates who haven't done CMT or IMT. It's a way of proving you're at the level to go into specialist training. And if anyone wants to discuss that out with this seminar, I'm very happy to share my experience of it. But as you heard, I started again last month, this time in Stevenage Hospital in the East of England as an ST4, although my hope is I'll be able to compress some of my training based on what I've done before. So I've clearly been interested enough in diabetes to have gone into it twice. Why? Well, I think a lot of you, if you've been on our diabetes general medical wards, you probably don't see the full breadth of what we do or what fascinates us about diabetes and endocrinology. Here are some of the answers I thought of, or colleagues and friends have thought of. I think it's really exciting that there's this great mixture of emergencies, of acute medicine, chronic disease management, and general medicine. And I don't think you can be a good diabetologist or endocrinologist without being a general physician at heart. And there's different mixtures of those that are going to interest different people. And there will be, in the bigger hospitals, consultants who only do diabetes, only do endocrinology. Some consultants will do a lot of general medicine, some will do not at all. So you're going to be able to find your niche and find a role that suits your interests. It's a multi-system disease. It's the pancreas in a lot of the cases that's caused this trouble, but it's not the organ we think about the most. We've got to think about everything. And there's a real opportunity to change long-term outcomes for our patients. If I think about something like the diabetes foot clinic, having a diabetic foot ulcer and having to come to clinic actually confers quite a bad prognosis that this patient with diabetes has. The risk of dying within a year of attending a diabetes foot clinic is 10%, and it probably has a 5-year mortality of 60%. So that's comparable to bowel and bladder cancer. So we've got a real opportunity to make real changes in outcomes for patients. We've also got opportunity to change outcomes for patients who aren't even born yet. In our antenatal clinics, when we see women with gestational diabetes or pre-existing diabetes, we can help women to manage their diabetes in a way that reduces the risks to the baby antenatally as well as postnatally, and even in that baby's long-term risks of type 2 diabetes and obesity. We can't do this, obviously, without an excellent multidisciplinary team. Diabetes specialist nurses and educators, dietitians, podiatrists, psychologists. So it's a great specialty for being part of that team. And of course, the most important person in that team is the patient, who we are asking to think about diabetes pretty much all the time. It's not something that a person with diabetes can ever put down. And so there's a real role for patient education and empowerment with structured education, with ongoing support to help a patient manage their own diabetes. If a person with diabetes comes to clinic twice a year, sees somebody for half an hour each, that's 0.01% of their year, leaving 99.99% of their year on their own as such. Although there's obviously always support available from teams. And doing that problem solving of working out how to help somebody manage their diabetes in conjunction with a patient and having those long-term relationships with a patient is really exciting. We have, as diabetologists, a finger in every pie. 20% of inpatients have got diabetes, 30% in patients over 65, and every specialty will come across patients with diabetes. We've already talked about the patients in the antenatal clinic, so working with diabetes midwives and the obstetricians. In the foot clinic, we work with vascular surgeons and orthopedic surgeons, renal physicians. We've got a lot of places where we need diabetes input. And there's a lot of really exciting drug and technology developments. I think in the time since I've been away from diabetes and returned, we've seen an explosion in access to technology for patients with type 1 diabetes and increasingly, hopefully for type 2 diabetes, with things like flash or continuous glucose monitoring, and the drugs that are available, different insulins, different drugs for type 2 diabetes and obesity. And wherever you work, there's going to be opportunity to get involved in research and national audits and guideline setting. So you're going to be able to find what interests you and find where your interests are in diabetes, your niche. So hopefully I've convinced you that this is something you want to do now. And then you need to think about how you're going to get appointed as an ST4 in endocrinology and diabetes. And I would suggest this is a good place to start. This is the website where you can get all the information for all the specialties that do the recruitment through this, about how the application process works, the point application scoring, and the interview, how that will work. So that's the first place for you to start. And points for these applications and interview, points mean prizes, in this case a job. So it's worthwhile thinking early and looking to see where these points are available and what you can do to demonstrate your interest in our speciality and also to increase those points on the application form so you can join us. One of the good places to start is by doing presentations. Those can be local, regional, national. You get more points for national conferences, posters, presenting them at conferences, publications, if you can, particularly if it's an original research publication, you get more points for that. And quality improvement projects, which might be a way to get some of these presentations, posters, and publications, which you'll get maximum points for if you lead that project and if you're involved in all aspects over 2 cycles. So you're going to need to think about this for those points really quite early on. And if you're not sure how to do one of those, if you want it to have a diabetes interest there, then go and find a local diabetologist. I've never met one who isn't friendly, so I'm sure would be keen to find a project for you. Another thing that is important for us all as doctors, but also for applications, is teaching. So depending on what stage you're at, there might be opportunities to get involved in foundation year teaching or medical student teaching, getting trained in how to do teaching. I've stuck this here because I'm an ALS instructor, but there's other ways to get training in teaching, and some people at some point during their training will do a postgraduate certificate in medical education, and also thinking about where there are opportunities to demonstrate leadership and management skills. Now, this can be local or national level, and it can be medical or non-medical. And I stick this here because in my recent ST4 interview, it was my role. I have some regional roles in Girl Guiding, a Brownie and Rainbow Leader. It was my role in Girl Guiding that they wanted to ask about. So there's lots of opportunities to demonstrate what your skills are. Now, compared to last year, and comparing the upcoming application, you no longer get points for having an additional undergraduate degree, but there are extra points for having a postgraduate degree and additional achievements or prizes as either an undergraduate or a postgraduate. And of course, and this should obviously be one of your priorities, is getting your MRCP. And through this all, thinking about how you can demonstrate commitment to our specialty. There's a lot of points available for this, so being able to demonstrate that is really important. And obviously we want you to have a real love and interest in the specialty as well. So taking opportunities where you can to demonstrate why and what interests you about this. One of the ways of doing that is by joining the Society for Endocrinology. You've obviously already found the link to the webinar today. And anybody who's an undifferentiated clinical trainee, this says up to CT2, but I've had it confirmed this evening that includes IMT3 as well. It just hasn't been updated yet. So anyone who's an undifferentiated clinical trainee or a student can join for only £10. And through that, you can apply for a really quite sizable grant to attend the BES, the annual Society for Endocrinology conference. And there's other opportunities. I've picked this off the website. This is last year's Student Video Award, but I imagine there'll be something similar next year where you can make a video about something endocrinological or diabetological to share and potentially win a prize for that. One of the things I do because of my 5 children at home is train less than full time. I think endocrinology is a really good specialty for that. And I think one of the things that really comes across from speaking to a lot of my colleagues is that the work-life balance is good. These are some of the tips that people have given me for training less than full time. I think some of the most important ones would be to try and take opportunities, to make opportunities, to ask for opportunities, and to try and get things done early. This is probably true for everyone, whether you're training less than full time or not. To maintain good boundaries between work and home. Again, that's something that's important for all of us, especially as more and more work has bled into home life with home working during COVID. Doing a good handover, maintaining clear expectations about what you can manage, and being kind to yourself. Now, the best advice I got after asking about this on Twitter was from Katrina Waite, who's the Professor of Clinical Pharmacology at Liverpool and is a mother of 5. So I felt some affinity towards her, who says, whatever you do it wholeheartedly. Don't compare yourself to others. It's not a race. And being a registrar 15 years on from when I was first a registrar, I definitely agree with that. So finally, what are my top tips? Find a friendly diabetologist and see what we really do as registrars and consultants when we're not on the wards. Come to clinic, come and join us when come and join the registrars when we're seeing referrals, and begin to think now about your application and take, make, and ask for opportunities. We love our specialty and we'd really love to share it with you. Thanks very much.
That's absolutely fantastic. Thank you so much, Kerry. I think there was some really interesting insights, some inspiration, and some top tips there. We'll move on, recognizing time, to Shivani. So Shivani is a Wellcome Trust Career Development Fellow and a Senior Clinical Lecturer in Diabetes at Imperial College London. She's also an Honorary Consultant Physician in Metabolic Medicine at Imperial College Healthcare NHS Trust. She's a clinical scientist leading a portfolio of studies that investigate early onset type 2 diabetes and has a specific interest in the presentation across different ethnic groups. In 2021, she was awarded a very prestigious Wellcome Trust Clinical Career Development Fellowship for 5 years to study the genetics and epidemiology of early onset type 2 diabetes in different ethnic groups, and is also an NIHR co-investigator on a grant studying optimal treatment for early onset type 2 diabetes. She's co-chair of the ADA Working Group on Precision Medicine for Type 2 Diabetes and Diagnostics, and was clinical advisor to the English National Diabetes Audit Analysis for early type 2 diabetes. So quite an incredible CV, and it'll be fascinating to listen to her now. So thank you for joining us.
Thank you so much, Tim, for that lovely introduction. And hello to all 47 people on this Zoom, and thank you for turning up to listen to us. And I was really inspired by Kerry's talk. Thank you, Kerry. It was so great to hear about your development over the years. So you've kind of heard the sort of précis of where I'm at as a consultant and clinical academic. And so this is me. I thought I'd just itemize when I qualified, when I got MRCP, and please don't try and work out how old I am, because we don't need that calculation. But as you heard from Tim, I'm actually masquerading here on the as an endocrine consultant, because actually I trained in metabolic medicine, and some of you may have heard that career about that specialty, but actually metabolic medicine has got some overlap with endo, and the bit that overlaps is diabetes, and so that's how I've ended up also specializing in diabetes and becoming a researcher. So that just gives you a few dates, and you'll see there that I did an MSc. I also did an intercalated degree during medical school, and then I did a PhD. And so you'll already start to see that quite early on in my career, I was very much focused on research. So if I move on, so the title of this seminar is Why Diabetes? And I want to take you back to 2007, which is actually when I was trying to decide what to do. I was back in the day, it was called core medical training. So I was just got my MRCP, and I was really interested in endocrinology, but the thing that was putting me off endocrinology was actually diabetes. I despised diabetes, and I still think that's sort of quite hilarious today, that I almost didn't do it, despite how much I love it right now. And why did I not like it? And I wonder if this resonates with any of you, because I've had conversations with some of my trainees about this. So I didn't enjoy diabetes as an SHO or IMT or, you know, house office or F1, F2, because actually on reflection, after medical school, practical hands-on diabetes training was quite poor. At least it was when I think back to my own training. And I had this real fear of dealing with diabetes in patients in hospital. And it was a fear around all of the treatments. I mean, let's face it, all of the pens sound the same: Humulin, Humalog, Humalog Mix 50, Humulin I, Humulin M3. I mean, it's a bit of a nightmare scenario. And of course, you'd come across these patients doing weekend ward cover, which was the worst shift for me. And I feared seeing these patients because I didn't know what to do. And my confidence always comes from knowledge. So not knowing whether it was safe to increase someone's insulin, should I go up on their glycoside, what should I do with the sliding scale? And there was always this, there was very little support. And for me, that lack of knowledge translated into not enjoying diabetes. The inpatient diabetes experience is also very different to the outpatient diabetes experience. Kerry's touched on some of the fantastic specialist clinics we have in diabetes, looking at pumps and glucose monitoring and islet cell transplantation. And it's so diverse and interesting, but the inpatient experience, which up until now, most of you will only have had predominantly inpatient diabetes experience, is very different. And it's sort of coming across general medical patients, you know, making changes to glucose lowering therapy. You're just sort of scratching the surface and never really getting into the details. And so all of these things were what were going through my mind as an SHO. And I did what most of you would probably do. I went and spoke to some endocrinology consultants, and I said, I did my undergraduate training at Barts, and I spoke to some people at Barts, and I said, look, like endo, but I really don't like diabetes. What should I do? And they said, well, no specialty is perfect. And so, you know, diabetes might be your least favorite aspect of this specialty. So, you know, go for it because there's other things that you like. So I joined as a metabolic medicine trainee in 2009, and I was assigned to the type 1 diabetes clinic as an ST3. And I was really scared. Okay, I don't mind admitting that I had no clue what I was doing. And we used to have this really big post-clinic MDT where you had to present everything. And it was not a fun experience, but the team was incredibly supportive. And often it's really inspirational consultants that change your career trajectory. And having gone into this really not enjoying diabetes, when you have good colleagues and seniors training you with enthusiasm, and this is in abundance in the endocrine and diabetes specialism, when you have those sorts of people, it's a bit like a drug and you start getting addicted to it. And so I came across this patient in around about 2010 or 11. So I was a year 2 registrar. And this is a really interesting case, which I just want to talk about for a second. So we had a 31-year-old British Indian woman, and she'd been diagnosed with diabetes 10 years previously. And she had no family history of diabetes. Her BMI was 18, which is very lean. And she'd been on metformin for the last 10 years. And her HbA1c was 62, which is, could be better. And the question was raised whether this could be monogenic diabetes, which is a genetic form of diabetes. And I was absolutely fascinated by this concept of monogenic diabetes, because up until then, I sort of heard of it, but I'd mostly, seen people with type 1 and type 2. And so over the course of years, my research and work has kind of focused on classification of diabetes. And I often talk about the bucket concept. And if we take this lady who I just described, and who, frankly, any of you could see on the wards, she might have come in for an operation, or may have come in with a chest infection. And so my approach is to think, well, monogenic diabetes is really rare, but type 1 and type 2 are more common. So does this patient neatly fit into the type 1 diabetes bucket or the type 2 diabetes bucket? And some of you will already be thinking that she doesn't, but let's break it down. So she was diagnosed at 21 and is lean, and those are things that we associate with type 1 diabetes, but it's 10 years in, and although her HbA1c isn't perfect, she doesn't need insulin. She's not insulin dependent, and that goes against type 1 diabetes. So you might be thinking, well, maybe she's got type 2. And in favor of type 2 is the fact that she's not required insulin, so the corollary of the other side. But going against type 2 is the fact that she has a BMI of 18, and that's very lean. And some of you may have heard that Asian people develop type 2 diabetes at leaner BMI, and you're right, but even so, 18 is completely normal. And so on the basis of this, we went on to do some specialist tests, and some of you may have heard of these tests. So we wanted to look at how much insulin she was making, and that was the C-peptide level. And we also tested her for pancreatic antibodies, which, if they're positive, can indicate type 1. And what we found was that her antibodies were negative, and she was still making a decent amount of C-peptide. So we went on to do genetic testing. And to cut a long story short, she turned out to have this rare form of monogenic diabetes called HNF1 beta. And HNF1 beta is a transcription factor. And she had a whole gene deletion of this transcription factor. So she had lots of these multi-system features. Metformin wasn't the right treatment for her. She should have been on insulin. And there were lots of other things that we were able to screen her for. And she's still under me in the diabetes clinic. So we were able to reclassify her after 10 years of this incorrect diagnosis. And the other major outcome, though, was that I was hooked. And if you talk to consultants, they often talk about a patient or a clinic where, something happened and they got hooked. I was completely hooked. I loved the idea of using biomarkers to classify diabetes, the fact that there were these genetic forms hidden. I thought the heterogeneity with which diabetes presents was amazing. What I had learned at medical school in the textbooks just wasn't the case. Type 1 can occur in overweight people. Type 2 can occur in lean people. But also knowing, as you now know, that I had the research bug throughout my training, the opportunity for translational research in diabetes, particularly in the UK, is huge. And some of the universities in the UK are ranked as one of the as #1 centres in the world for diabetes research. So in the UK, there's a huge focus on research. And so I went through, as you've heard, to undertake a PhD. And this patient was sort of one of many that I had seen who helped formulate a research question. And you can sort of fast forward through. I got funding for my PhD, I became a consultant, and then more recently I've got one of these intermediate fellowships, which now allows me to drop down more clinical activity and focus completely on my research. So if some of you are thinking about doing research, diabetes and endo is a really nice specialty to do, because it has the opportunity, huge opportunity for translational research. And you know, there's so much work going on in diabetes, whether it's type 1, type 2 prevention, monogenic diabetes, and you'll be familiar with this sort of pathway that can be taken for research. But in reality, the pathway looks more like this. This was certainly my pathway. If you're looking at my timeline and thinking, oh gosh, that's so perfect, she had such a perfect pathway, that's just because of the way I presented it. My pathway, just like Kerry showed with the meandering river, I smiled when she showed that, because everyone has their own pathway. And although it looks like some people are here on the left, most of us are meandering our way through. And so one of my top tips about whether or not to do a higher research degree like an MD or a PhD is to really think about your motivation for doing it. And maybe we can talk about this in the panel discussion, because some of my friends did PhDs, not in diabetes and endo, but in other specialties, and they felt like they had to do it to be able to get the job that they wanted to do. And maybe that's the case. I hope that that's changing, but I've certainly heard in the sort of London setting, you know, doing a higher research degree seems to be the norm, but should it be? And even as someone who is, you know, committed to research, I do think that sometimes people do it for the wrong reasons. And the reason that that's important is because it's 3 to 4 years out of your life. And if you don't enjoy it, that's 3 to 4 very miserable years. So the real academic journey, and I was asked to sort of focus on academic journey in this talk, is that you have to be prepared for things not going to plan and some setbacks, but it's your passion for research and mentorship that keeps you going. But one thing that I do want to say, and this doesn't just apply to academia, it also applies to people who are clinicians without research, and Kerry touched on it as well with that tweet, is to avoid comparison. And there were times when I really compared my own trajectory and pathway to other people who are at the same stage as me. And it really doesn't help, because you compare yourself to another person in that snapshot of time, but all of the decisions that led you to those respective points are completely different. So it's a completely false comparison, and try your best not to do that. So one of the things that, and I've got 2 more tips to give you. So one of the things that I think really helps if you're considering an academic career is mentorship. And that's because what I've highlighted here in yellow are all of the setbacks that I had: grant rejections, slow recruitment to my study, more grant rejections, balancing clinical and academic work, huge feelings of inadequacy when you saw peers advance ahead of you. And everyone goes through these things. These are quite normal. So having someone that you can talk to is really important. And it's not just important on the research side, it's important on the clinical side. And one of my big tips, whatever you decide to do and whatever you do, is make sure you get mentors, more than one mentor if necessary, because they all have different perspectives to offer you. And I define mentorship in my own way, which is someone approachable and friendly who has experience and can provide objective guidance with no strings attached. So it's really important you get someone who doesn't have a vested interest in a particular outcome. So if you go for the wrong person, you might think that you're getting objective mentorship, but actually you're not. There are also schemes that allow you to, you know, develop networks of peers and also more formal mentoring. And if you're really interested in diabetes, the SFE has obviously got some great programs which you've heard about, but I just want to also flag a scheme that's available through Diabetes UK for younger scientists and researchers in diabetes. and also the European Federation for the Study of Diabetes, who have a mentorship program. And I benefited from both of these programs. And it might be a little bit early for you, depending on your stage, to apply for these, but I'm using them to illustrate how much support there is in our specialty. Our specialty is so geared towards career development, mentorship, and support. So here's me about, oh gosh, 8 years ago, is that? Looking thinner and much younger. This is a retreat that we had for innovators in diabetes. And most of these people are all consultants now across the country. And networking is great because it breaks down walls. You realize that other people have the insecurities that you have. It allows you to build networks of people to seek for support. And over the 3 years, you kind of, in this program, you get to meet everyone in your field. And here's me at the European Federation, also looking thinner and younger. And that was from about 6 or 7 years ago. And this is one of my mentors that I got paired up with. So through that scheme, I was able to travel to Europe, and she's a professor in Belgium, and she mentored me for over 3 to 4 years in the last 3 to 4 years as I've been getting my fellowship. So I cannot strongly enough recommend mentorship, whatever stage you are at. So I'm going to finish with this slide. Am I glad I chose diabetes? I can't tell you how much I despised diabetes as an SHO, and it really makes me laugh. But yes, I'm really glad I chose diabetes. It's an art, not a science. Every day brings different challenges. Every patient, I've been in an all-day clinic today, every patient was super interesting and has, you know, different aspects to consider. But as an academic, I love it even more because there's huge variety, and that variety is a big privilege. So if you're somebody that gets fed up doing the same thing again and again, being an academic, no day is the same. And there's a huge potential for global collaboration. So you've heard that I chair the American Diabetes Association working group on precision diagnostics. You get to meet and travel and have lots of fun. So I've probably overrun. I do apologize, but I hope that gives you a flavor of what it's like being a diabetes clinician and academic. And I'm very much looking forward to your comments during the panel. Back to you, Tim.
Fantastic. That was an absolute whistle-stop tour and amazing to see. And I've learned a huge amount from that as well. So thank you. And we're doing really nicely for time as well. So thank you for both speakers so far. Our last speaker is Ali. Ali is a consultant diabetes and endocrinologist at University Hospitals Birmingham NHS Foundation Trust. He's also an honorary lecturer at Birmingham University with interest in the role of technology in the management of type 1 diabetes and particularly medical education. He leads the Birmingham Type 1 service and is joint lead for the regional islet transplantation service with colleagues from Oxford. He is the training program director for diabetes and endocrinology training in the West Midlands region and a lead on differential attainment. He's a national recruitment lead for diabetes and endocrinology in the UK, which is very relevant to anyone thinking of applying to the specialty, and a local RCP regional advisor for the West Midlands. He's been a UK diabetes clinical champion and part of the South Asian Health Foundation Network, involved in writing reports around health inequalities for populations across Europe with diabetes. He's published extensively in ethnicity and diabetes and the use of diabetes drugs during Ramadan, insulin intensification, and cardiovascular disease. He's also my training program director, so we have to be very nice to him while we're on the call, but I'm sure he'll have some fantastic insights for us. So thank you, Dr. Karamat.
Thank you very much, Tim. And again, thank you very much for the invite. I think it's been absolutely fascinating listening to Kerry and Shivani, and I think you'll probably see quite a few bits which I'll talk about, which will have a few parallels. So I'll start with a little bit of a sort of an apocryphal story where before the time of the modernizing medical careers, there was this joke that you want to choose a specialty, go to the consultant car park and see which one has got this sort of a Bugatti. I think to own a car like that, sadly, you will have to be a non-academic nephrologist in the States. So might want to change your ambitions in diabetes and endocrinology if you're wanting to aim to own that. But it's just in terms of how you're actually aiming for a career, it's just useful to know a little bit about your drivers in terms of how you want to do it and what sort of specialty and what makes you decide that. So like the others, I will take you guys through a little bit of my career path, and I've presented it in the form of a what we call as a Gantt chart, essentially, which is my career progression. I am an international medical graduate. I know some of you have asked that question as well, being an international medical graduate, and I think that is an important point I'll make here because I will be quite relevant for a lot of questions which you guys ask as international medical graduate, and also working locally certainly on issues pertaining to differential attainment. So I'll hopefully try and address some of your questions. So I graduated. I'm not shy in sharing my age here. 2002-3 is my graduation. Then I came to the UK straight after doing sort of what's called as house officer jobs, the equivalent of FY1 now. Did a couple of years as a core trainee down in the land of Essex. And actually, then I got appointed as a registrar in diabetes and endocrinology. So I was quite lucky. I didn't have to wait a long time before I managed to get a national training number. I had to do what was called LAT in that time, a LAT, locum appointment for training. My academic training number was as an academic clinical fellow. This was, I think, the first time that scheme was introduced. And then I progressed to a clinical lecturer at the Birmingham University, and I was silly enough to attempt to do an MD alongside a full-blown clinical lectureship program. And I would never recommend it to anybody else. I think for your sanity, if you want to do research, please do it properly, like Shivani did. Take proper time out and actually have it structured in a way where you run it properly. I had lots of challenges, as Shivani alluded to, during research. My academic supervisor left the institute where I was based. I had to fork up some cost on my own to try and finish the project. It was very, very stressful. I ended up completing an MD in the end, though, and actually ended up writing my thesis after I'd been appointed as a consultant. I had always been interested in medical education, so once I became a consultant, I did take some roles. Firstly, as a Royal College tutor, and then also as a senior academy tutor for undergraduates. Following that, with my background, I thought I could actually support some of the international fellows which were being appointed at our trust and coming from another country, and I could actually share my experience with them. So I spent a couple of years being a clinical tutor for the international fellows at my hospital. Then I progressed to being a member of the Specialist Training Committee and eventually the training program director for diabetes and endocrinology. I was lucky enough to be recognized by Diabetes UK as one of the national clinical champions. And then I have, for the last sort of couple of years, taken over the role at the national SSE for the recruitment lead for diabetes and endocrinology. So that's a little bit about my career progression. And in terms of where I stand now, I'm also now one of the Royal College of Physicians regional advisors. What in terms of my research background? So if I talk a little bit about my research journey, which I'll keep very brief because you've heard from the expert in that, from Shivani. I started as an ACF, then a clinical lecturer, did an MD alongside that. I did manage to get an NIHR grant looking at preconception care in diabetes, and then was involved in some systematic reviews and sort of setting up some research courses locally for trainees. I've been a PhD supervisor for some students as well as a peer reviewer for the Academy of Medical Science and part of the Midlands Type 1 Diabetes Alliance, as well as on the SAF working group. And I'll shamelessly promote our SAF conference, which is tomorrow and day after. So if any of you have got an opportunity to come, please do come to our SAF conference tomorrow and day after in Birmingham or online. I think what I would like to say to you guys firstly is have a little bit of an idea in terms of how you want to plan your career. Be aware in terms of what you want to do. You've heard from Shivani, for example, that actually at the SHO level, she really didn't want to do diabetes. And you'll probably hear something similar from me. When I was first sort of came here and I was doing my core medical training job, my first option, like all of us international medical graduates, is, oh, I want to be a cardiologist or I want to be a gastroenterologist. I want to be shoving tubes down people. And I think after the first couple of colonoscopies I did, I was, I think, put off enough to say, Ali, I don't think this is for you for the rest of your life. So that was enough to put me off from certainly doing gastroenterology, but actually having a plan B and focus on some specialties, a couple of them where you actually want to build your career towards, and also build your application and CV form. I think Kerry has really nicely alluded to the points that you get in your applications and making sure that you actually do something relevant to the specialty. Our specialty has thankfully become really competitive over the last couple of years, and I'll be happy to talk a little bit more about that when we have the panel discussion, which is really nice to see. But it is important then that you actually show some commitment to specialty when you are applying. When we are looking at your evidence check for as a panel, or when we are doing your interviews, this is an important point that we would address, whether you have got the right way of showing commitment to specialties. Show some smart targets, show some opportunities in management and leadership in addition to teaching, as well as quality improvement projects. And also always remember you're in charge of your career. You can actually select what you want to do. So what about specialty of diabetes endocrinology? So what does my day-to-day work look like? I have a special interest in intensive insulin therapy, as well as I do some antenatal clinics and a bit of community diabetes. I do lead, as Tim alluded to, the type 1 diabetes services across, and also work around the community diabetes program around Solihull. In terms of education, I've got the hat of TPD and recruitment lead. But more interestingly, once I started in my consultant role, we noticed that there was not really in our region an islet transplant setup. So we set up with our colleagues from Oxford a joint islet transplant clinic. So we do that every month or every other month, where our colleagues from Oxford come, and jointly with them we run the clinic, and we run that regionally for the whole of the West Midlands, where we get referrals from all over. In addition to that, now we've also set up a pancreas transplant clinic jointly with our nephrology colleagues in Oxford. So this is all something which happened after I've become a consultant, and that's another important point to remember. I say this to all the trainees as well, that actually what your job turns out to be as a consultant really depends on how you want to take it forward. What you're appointed on the first day as a consultant is not necessarily what you'll be doing 5, 6, 7 years down the line. You have got that opportunity to evolve, you've got that opportunity to make the changes and drive your own career. And so it is important when you're selecting a place is actually who are your peers? Are you going to be actually getting on very well with that team there? And then you can actually develop some of the other elements as you move along. Like everything else, there is some general medicine component in my job. I work as a consultant physician covering general medicine on one of the wards. We lead a team of junior doctors. I also cover some inpatient diabetes sessions at Heartlands Hospital in Birmingham. And as I've alluded to earlier, I have previously worked as a postgraduate tutor as well as a clinical tutor for international fellows. I have managed to get a couple of PAs for some research work funded, although it is very difficult to actually ring fence that time. And if you can do it properly and through the route that Shivani did, then that would be much more what I would recommend if you are going to pursue your career in academia. As you can see, I've tried to keep a few hats on, and it's always a little bit difficult to juggle when you've got hats like teaching, management, and research on. Probably best to focus on one. And more recently, I'm also now one of the regional advisors of the Royal College, which gives me an opportunity to set up the local educational events, work with college tutors, the clinical fellows of the college, and actually do a lot more work nationally and hopefully moving forward internationally with the Royal College. There are obviously, this is just a little bit of a pattern in terms of what I would do on a day-to-day basis, just a job plan of myself and actually one of my colleagues, with his permission, I've shared this. So just as an example, I would have a ward round perhaps in the morning, and then I could have my type 1 clinic, which I do at one of the other sites, which is Solihull. Tuesday morning is always my antenatal clinic with a bit of admin. Wednesday morning is my other type 1 clinic, and generally mixed with an islet transplant clinic on that day. I could do some inpatient diabetes on a Thursday, and I still do have a bit of endocrine in my job plan. So I do an endocrine clinic on a Thursday afternoon. And again, depends on how you want to progress. So when I was finishing my training, I had an opportunity to decide whether I wanted to take a job which was pure diabetes or pure endocrine at one of the hospitals, or actually take a job where there was still an element of both. I wanted to keep both skills, so I decided to opt for this. But actually, you might want to select at that time that actually I'm interested in diabetes mainly, or I'm interested in endocrine mainly, and actually pursue the career that way. That's a lot of people actually do plan their career accordingly and work in that way, where they work just in one element rather than both. And a lot of teaching hospitals work that way. But there is a lot more leeway around that these days, and a lot more jobs which have got both components. Then a Friday could be my research session usually, or every other month we have the Reddish transplant clinic. And then I'm just sharing another colleague's job plan where it might have an endocrine clinic on a Monday morning, ward on a Tuesday, inpatient diabetes and a thyroid clinic on a Wednesday, again an endocrine clinic on a Thursday, and perhaps a young adult diabetes clinic on a Friday. So just sharing some examples with you in terms of what the day-to-day work might look like for you as a consultant. Where we are based, we are about a group of 8 or 9 of us who share the ward. So the actual general medicine is not too onerous, although we still share the on calls as well. So it's usually about 1 in 8, 1 in 9 kind of frequency of the work that we do on our general medical ward. But if you're opting for a job in a district general hospital, it might be a more frequent sessions on the ward, but less intense. With a big hospital like ours, it's a lot more intense, but the frequency is not as much as some of the other places. Look, there are always pros and cons of anything that you're selecting, any specialty that you choose. So, in terms of some of the pros and cons, you do have a real sort of varied clinical range of patients that you're seeing. I think the diversity of career options are fantastic. So you've heard from someone who's actually excelled in the field of academia. You've heard from someone who's actually really taken a fantastic route where they've looked after themselves and their family and then pursued a career. You've heard from me who's decided to go down more on the education route and actually decided to specialize around the education side a lot more, trying to still keep a bit of research hat on, but actually a lot more focused on the education elements. And you could hear from other people who might have a management and leadership role on, for example. They may be clinical service leads for a department, or they might take on roles such as medical directors at organizations. Lots of diabetes endocrine senior colleagues I know who have taken that roles and done that. Generally, we do have predictable working hours in diabetes and endocrinology. That's one of the advantages of not shoving down instruments into people. We don't have too much unpredictable working hours. And really an excellent opportunity for integrated clinical scientific research. I think that's really a very, very nice way of looking at it. Also, really good opportunities for flexible working. So I think probably about 10 to 15% at the moment of the trainees that we look after in West Midlands are part-time. But again, that will probably increase as we go along. And when we speak to people now, I think there's a lot more who want to work part-time, and I think there's a lot more understanding around it at senior level. There are acute medical commitments with a lot of the jobs in diabetes and endocrinology. So that's something which is worth considering. And some people are generally put off by that. But with the last couple of years, with the advent of the new curriculum and with the group and specialities, which majority of them are now, it has actually meant that we've had a lot more people apply for diabetes endocrinology than before. And with other specialties, for example, neurology, rheumatology, all now being group 1, it has meant that we've actually had a lot more interest in our specialty, which is really nice to see. There can sometimes be some work that you need to do and sort of on the medical politics side of things with management and others. So I've had to do a couple of times interesting business cases. We still are working on a business case locally, looking at expansion of our type 1 service. We had to set up a business case for access to some of the technologies such as continuous glucose monitoring, for example, in our patch before it had become more sort of readily available in the NHS. And again, working with the commissioners and trying to work and understand that through different routes was really, really exciting and interesting. And although it sounds boring, it actually, once you know how to do it and you start putting the figures in, it can actually be quite interesting and work in your favor. And you can actually then guide people around how to approach that. So I think that's probably the gist of what I was going to say. Just a few major points in terms of advice with regards to recruitment and from some of the experience that I've noticed for the last few rounds that we've done. I think the evidence check is important, that you don't undersell yourself, but also don't oversell yourself. The guidelines are pretty clear. We actually have made it very, very clear. For example, the different points for how much you've contributed to a quality improvement project, for example, how much you've done and where you've presented in the teaching conference, for example, where is it peer reviewed publication. So we've had some applications, for example, where people have put down a peer reviewed publication, but then we actually have searched in PubMed, not seen that, for example. We've also had some applications where people have come from overseas and perhaps not understood the difference between the fellowship in their own country and the membership here, which are considered equivalent for the purpose of the application. So there are some little sort of nuances which do make a difference in terms of your application. But try and be positive with your scoring, but also not overdo it, because that doesn't look nice. And actually having something to show positive in terms of your commitment to specialty is really useful. And if you are able to and get a chance, attending some clinics is really, really important, because some of the scenarios you'll have in your interviews will be focused on what we would normally see in a clinic setting or in an acute medicine setting. So important to familiarize yourself with some simple scenarios which we would see in our diabetes or in an endocrine clinic. So those are some just little practical tips which I would give you guys from a recruitment point of view. And I think I've rambled on enough now. I'll stop sharing and happy to take any questions.
Thank you, Ali, and almost completely on time. So well done, all three speakers. That was fantastic, and I think those later insights into the application process will be invaluable to those on the call and mirror some of the questions we've had already. So thank you. What I will now ask all the speakers we've had so far to do is come back onto the screen. Feel free to unmute and put your cameras on, and we will go through the questions that we've got already. And I'm really hoping that we can get some more questions, because this is your opportunity to ask three really diverse and amazing speakers about whether you should choose this specialty for the rest of your life. I think overwhelmingly the answer is yes, from what we've had so far, if it's something you're interested in. But this is your chance to ask some questions. So I'll start with the first question. And it was addressed to one person, but I'll perhaps open it up to all. Is there any advice for international medical graduates interested in D&E who've completed the MRCP, they've got experience in internal medicine in their home country, but not official training, and are now starting on their NHS journey? Would you think it's beneficial to start at IMT level or get some experience to get alternative competence certificates and apply straight into ST4? So it's quite a detailed question, and I'm not sure we could quite give the personalized exact answer, but if anyone has any thoughts about it, please do chip in.
Yeah, happy to take that, Tim.
Thanks, Dr. Kama.
So I think the first point of advice I would say is important to get some UK experience. One point which is worth remembering is that now you're applying for ST4 level, and you'll be expecting to work as a slightly senior medical registrar. Most hospitals are expecting ST4s to be the higher sort of member of the team, and then an IMT3 could be placed with you, for example. So if you haven't actually got that experience of working as a medical registrar and you want to straight away apply for that, then I think you can actually come up stuck. And we've had this kind of highlighted following the last couple of rounds of recruitment, where some people have really struggled when they haven't had a chance of working or getting much experience in the UK, and then have been appointed at ST4. And particularly with the medical registrar work, they have really, really struggled. Not per se in sort of clinics or in an outpatient basis, but with the medical registrar on calls, which is really a large part of the work as well, they have really struggled. So my advice in a scenario like this is to speak to your supervisor, because even if you're in a non-training post, you should have a supervisor who will be able to advise you based on how they assess your competence, whether you are at that level where you can apply directly at ST4 level. And if they feel you are, then you can get them to sign your alternative competency certificate and apply directly at ST4 level. If they feel you will benefit from attending the IMT3 program, then it's probably better off in the long run to come through the IMT route and actually follow that properly. So I hope that sort of covers the answer.
Thank you, Ali. Do our other speakers have anything they want to add to this at that point? No. So I'll go with the next question, which I think perhaps we might start with Shivani, because it's got an academic element to it. So do you have to go through ST4 to ST7 after your 3 years of academia in endocrinology? I assume that means a PhD. Shivani, do you want to take that?
Sure, yeah. So, I mean, it might mean a PhD, and the answer is no. So you can count some of your PhD towards your training, which I did. I counted a year. Is conventional is up to a year. So if you did a 3-year PhD, and you went out of program, when you come back in, you can advance 1 year in the ST program. The other thing that you might be thinking of there is if you're an ACF, if you start off as an endocrine ACF, and when you're an endocrine ACF, 4 months a year, you'll be doing a project, but you advance through, so ST4, ST5, ST6. And the idea is that during that academic clinical fellowship, those 3 years, you use those 4-month blocks to get funding for a PhD. And you don't have to complete those 3 years. As soon as you get it, you can go out of program, do your PhD, and then come back in again and count a year if you want to. And some of my friends that I was doing PhDs with at the time, they didn't count a year. They wanted to come back in. And, you know, having a gap of 3 years, especially if you're doing GIM, you know, a lot of people felt that they didn't want to accelerate their training. So when I came, if I hadn't counted my training, my 1 year of my fellowship, I would have come back in and had 1 year and 5 months left, but I decided to count a year. So I had 5 months left when I came back in. So the answer to your question is, yes, you can count a year of your PhD towards your training.
Thank you very much. We're starting to get some questions, so we'll move on to the next question. And actually, I think this is open to everyone because each of you works in a different area of the country. Is there any information as to which registrar rotations or deaneries offer more protected D&E time and less AGM, which I assume means acute general medicine commitments? Kerry, do you want to start?
Yeah, I'm not aware of that information being available, but I think it's going to depend on the different hospitals where you are as well. That when we're in district generals, there's going to be probably a greater proportion of acute and general medicine than when we're in tertiary hospitals. I think, though, not to see the time in doing acute general medicine as wasted time, though. I think it is such a good opportunity to see an awful lot of very interesting pathology. And I think we are, maybe every specialty says this, I think we are maybe some of the last specialties that practice proper general medicine. We have every organ that we think about. And thinking about, I was on nights just a few nights ago, and I saw proper endocrine problems like amiodarone-induced thyrotoxicosis type 2. I was diagnosing on the acute medical take. So none of this is wasted, and we'll all, I think there's a real sense, some people think of the general medical blocks as a waste, but that's where we get a real opportunity to practice an awful lot of medicine and to do a lot of the acute diabetes, acute endocrinology on the wards when we're on seeing referrals. I think it's another really good opportunity.
Thank you. I think that answers that really comprehensively. So yeah, with sport for choice, who could answer the next question? And that is for internal medicine trainees are planning to apply to ST4. How is that? What is the best way to open doors into clinical research if working in DGHs and non-university hospitals? And I'll open it up to everyone because I think you've all got some experience that would answer that. Shivani, would you want to start perhaps?
Yeah, I'll go first. I think it's a really good question. And I would like to say that I think diabetes really lends itself to being able to address this issue very easily, because 30% of inpatients have diabetes. You are basically sport for choice. And the pandemic really showed this. Some of the most amazing studies came from clinicians that were just collecting data on patients that were coming in with diabetes emergencies. We did it here. We published a series of DKA in people with presenting with COVID, which was one of the first reports. And if you're interested, reach out to the diabetes consultants, because they're all, you know, diabetes and endo is intrinsically an academic specialty. You have to keep up to date. You have to read the latest guidelines. It's needed for your clinical practice. So even if you're in a DGH, and I don't say even if, I actually think some of the best clinicians and clinical studies can happen in DGHs. So reach out to a nice friendly diabetes or endocrine consultant and talk to them about projects that you could do, because there are no shortage of patients. And even if it starts out as a sort of quality improvement project, that can lead on to a publication. And the other thing in diabetes is we have really big national audits that all trusts have to report to. So for example, if there are inpatient DKAs where the person's come in with something different, but they've developed a DKA on the ward, that is a harm that has to be reported nationally. So you could get involved in contributing to those audits. You could do a quality improvement project. You can also write up interesting patients. So reach out to the diabetes and endocrine team and voice your interest, because everyone's very busy. It requires a certain amount of enthusiasm, right? So if you go up to someone and you keep contacting them and show your interest, someone will latch onto you, and then you'll have a foot in the door. That's what I used to do anyway. I used to stalk interested staff members.
Fantastic. I think that's a gold standard answer to that question. So thank you, Shivani. The next question I might ask to Ali, any scope of Caesar route in diabetes and endocrinology?
Yes, of course there is. I think generally the process for Caesar is that it's reviewed at the level of the national SAC by a group of TPDs. So we're all part of that national panel where we review the applications. There are some changes coming up to the Caesar route, so I'll suggest to anybody who's interested in that to keep an eye out for it, which might make the process easier or more difficult. We'll have to wait and see. But previously, the way the Caesar route has been handled is you need to show some commitment essentially to the curriculum. So what I would advise people to do if they want to do the Caesar route is to look at the new curriculum and actually see how are they going to meet most of the objectives of the new curriculum if they are planning to apply for the Caesar route, because that's the way we assess it, essentially the competencies according to the curriculum which is in existing at that time. So on the GRCPTV website, you can access the most up-to-date diabetes and endocrine curriculum, look at that and try and follow that.
Fantastic. Thank you, Ali. So we've got another question, which is someone who spent quite a long time working as a medical support worker whilst awaiting GMC registration in a diabetes and endocrine department at the hospital in the Oxford Deanery, attended more than 50 outpatient appointments, shadowed the NSPR, and worked as a general SHO on general medicine. How are they best to evidence this time worked and the varied clinics they attended? I'm not sure whether that is as credit for a Caesar or on application. Do you want to just indicate in where you're trying to show that, Remy, in your question? And we've got 5 minutes left while Remy's just perhaps updating that. Please, if anyone's got any final questions, have a think about them. Please pop them in the chat now. While you're doing that, I will ask Kerry a question that came up during her talk that I wanted to ask, which was, is there a particular time during medical training from F1 to CCT and beyond that it's a good time to take less than full-time training to start that journey, or are there times where it might be better to hold off, if that makes sense? When's the best time to do it?
That's going to be a really tough question to answer. I suppose that for many people, getting the foundation years done and out of the way probably makes life a little bit more flexible. Less than full-time training does lengthen things out quite a bit, and so there are costs to that, but there are also great benefits. And I think there's certainly a move now to a lot of people working less than full-time and training less than full-time. It doesn't just need to be because of childcare responsibilities. It may be harder, I think, to get I think it's tier 3 less than full-time. But I think as a registrar, it's working well that I can balance what I have to do at home or my other responsibilities outside of work with what I'm doing. But it's, as with everything, it involves just an awful lot of organization.
Fantastic, thank you. Remy's come back to us, and it's for IMT applications, which is probably a stage before applying for specialty, how you would sort of document that evidence. Does anyone have any suggestions for Remy?
I think I've commented it's probably best to do it through a logbook. If you,
I see.
yeah, I think that's probably the best way to capture that would be through a logbook, I would suggest. But at an IMT level, I'm not sure that would be necessarily that much necessary. I think it's during the IMT if you can show some evidence. One other point to make here, which people tend to get very nervous or anxious about, is if they haven't done an IMT3 in diabetes endocrine, they feel like they're going to get left behind. Absolutely not. We are very clear that we can't penalize someone for not managing to get an IMT3 in diabetes endocrine. So even if your IMT3 post is in geriatrics, for example, but you want to do a project in diabetes and show the commitment to specialty that way, you can easily do that.
That's very helpful. Thank you. In which case, I think we've answered all the questions in the chat. Most importantly, I want to thank all our speakers. There's been an incredible breadth of insight, inspiration, top tips, and I think it's one of the best actually sessions that we've seen on the Taste Days for a number of years since we've been running them. So thank you so much to all three of you for doing that. Thank you also everyone for joining. In case you missed anything, the session is recorded and will be sent out. And I do particularly want to mention that after the webinar, it might take a few days, you'll get an email. It will be about how to join SFE. You've heard about all the wonderful opportunities that SFE offers. It will contain some materials from this webinar, from another webinar we've had as a taste today. And also, I think for the first time, there's an opportunity to have a free sort of tutorial in diabetes insipidus, which is something that's normally only offered to SFE members, but you'll be able to have a look at that, learn from that, and see whether you want to join SFE. So thank you so much to SFE for organising. Thank you again for our speakers, and thank you everyone for joining. And yes, the recording will be accessible later. Thank you.